Dear students, now let me discuss a very important clinical conditions which we come across very commonly in our day-to-day practice, that is hypertension. Now, if you see this particular hypertension, what are all the subtopics under which I'll be discussing hypertension is, I'll be discussing the types of hypertension, that is the primary and as well as the secondary, and following which I'll be discussing the etiology of the secondary hypertension. And later on, within this particular hypertension, I will be discussing what is called as hypertensive crisis. And I will also be discussing what exactly are the drugs which you need to give for hypertension in various clinical scenarios. And lastly, I'll be discussing about what is called as resistant hypertension. So, now let me discuss the topic of hypertension. Now, if you take this hypertension, see, this is how the questions can be framed on this particular topic of hypertension. The question is, what is the most common cause of hypertension in adults? The options are essential hypertension, option B pheochromocytoma, option C renal artery stenosis, option D the chronic glomerulonephritis. Now, so to answer this question, first you need to know what exactly are the types of the hypertension, and later on I will tell you which is the most common cause for the hypertension in adults. Now, so if you see this hypertension, we can classify this particular hypertension into primary and as well as the secondary hypertension. And remember this point here, the word primary hypertension, this is also called as the essential hypertension. Right, this is also called as the essential hypertension. Now, a very important point that you should remember here is, out of this primary and secondary hypertension, the most common cause for hypertension in adults is the primary or essential hypertension. So, this is the most common cause. Next, this essential hypertension, it accounts for nearly around 85% of cases. Right, it accounts for nearly around 85% of cases. Next, the other important point what you should remember in case of primary or essential hypertension is that in case of primary or essential hypertension, we don't have any underlying cause. What exactly is the cause for essential hypertension? It is idiopathic. Right, it is idiopathic. We don't know what exactly is the cause for primary or essential hypertension. And what you should remember is about the family history. Almost 70% of individuals, they will have what is called as positive family history. Okay, 70% they have positive family history of hypertension. These are some of the points about your primary or essential hypertension. What exactly is the cause? Is idiopathic. We don't know what exactly is the cause, and this is the most common cause of hypertension in adults. Next, let me take up the another clinical condition causing hypertension, that is secondary hypertension. Remember, in case of secondary hypertension, there is certain underlying etiology making the individual to land up in hypertension. That is what is called as the secondary hypertension. This secondary hypertension, it accounts for nearly around 15% of cases. Right, this will account for nearly around 15% of cases, whereas 85% is your primary or essential, where the etiology is idiopathic. Whereas in case of secondary hypertension, the individual has a specific disease. Right, the individual has a specific disease. And because of this particular specific disease, the individual will develop hypertension. Now, what I will do is, I will tell you what are all the etiologies which will cause the secondary hypertension. Now, the etiologies causing secondary hypertension include taking all the way from the renal pathologies, right? First and foremost, let me discuss the most common cause of the secondary hypertension. Remember, the most common cause of your secondary hypertension, it includes mainly the chronic glomerulonephritis. Mainly it is the renal pathologies which will contribute to your secondary hypertension. So, if you take the etiology of secondary hypertension, in which we have what is called as the renal causes. Next to the renal causes, we have certain endocrine causes. Right? Next to the endocrine causes, we have certain cardiovascular causes itself. Right? Cardiovascular system causes itself. And later on, we have certain drugs as well. Right? Later on, we have certain drugs as well. Now, first let me tell you the renal pathologies. The renal pathologies, as I have said you, it is your glomerulonephritis. So, particularly chronic glomerulonephritis is the most common cause for your secondary hypertension. And apart from this, now you take a clinical scenario where there is infection related to the renal parenchyma. And what is that? It is pyelonephritis. Remember, it is acute pyelonephritis which will not cause secondary hypertension, but it is mainly the chronic pyelonephritis will cause the secondary hypertension. Next, we have a clinical condition within the kidney where you have the formation of multiple cysts in the cortex and as well as in the medulla, or particularly in the corticomedullary junction, and that is what is called as polycystic kidney disease. So remember, in patients with the polycystic kidney disease, they can have this secondary hypertension. Right? Polycystic kidney disease. Now, the other very important cause for the hypertension is any abnormality within the renal vasculature. For example, if the individual is having renal artery stenosis, in patients with the renal artery stenosis, the renal perfusion will be reduced, and thereby there is activation of renin-angiotensin-aldosterone system, resulting in what is called as the hypertension. So, once there is activation of renin-angiotensin-aldosterone system, there is excessive formation of angiotensin 2, and that will cause vasoconstriction, and that will increase the blood pressure of the individual. So, remember, renal artery stenosis. Right? Renal artery stenosis is another important renal pathology which will cause the secondary hypertension. And next we have the collagen vascular diseases. Right? Collagen vascular diseases, which will contribute to the development of hypertension. Next, now let me tell you the endocrine causes for hypertension. Now, if you take the endocrine causes for hypertension, remember a very important point here. We have a clinical condition which is where there is tumor originating from the adrenal medulla, that is called as pheochromocytoma. In pheochromocytoma, there is excessive production of catecholamines, that is mainly your epinephrine and as well as norepinephrine. Epinephrine and norepinephrine, they will act on the blood vessels and they will cause vasoconstriction, and that will make the individual to land up in hypertension. So, the endocrine conditions include number 1, pheochromocytoma, where it is the tumor of your adrenal medulla. Next, now we have another clinical condition which is characterized by excessive production of corticosteroids. Right? Excessive production of corticosteroids. Now, what is the endocrine disorder where there is excessive production of corticosteroids? It is nothing but your Cushing syndrome. Right? It is nothing but your Cushing syndrome. So, Cushing syndrome is the disorder where you have excessive production of corticosteroids. So, remember, corticosteroids, what exactly they will do is they will upregulate the alpha receptors on the blood vessels, and thereby they will increase the sensitivity of your epinephrine and norepinephrine, and thereby that will cause excessive vasoconstriction, and that results in what is called as hypertension. Next, we have a clinical condition where there is excessive production of aldosterone. Now, what is that clinical condition where there is excessive production of aldosterone? Remember, it is nothing but your Conn syndrome. So, Conn syndrome is a clinical condition which is characterized by hyperaldosteronism, where there is retention of the sodium and water, and thereby the fluid volume increases, and thereby the blood pressure of the individual increases. So, the other condition what we have is the Conn's syndrome. Next, next to the Conn syndrome, we have the disorder related to your thyroid. You take in patients with hyperthyroidism, they will have what is called systolic hypertension. So, conditions like hyperthyroidism, they can have systolic hypertension particularly. Next, you take the clinical scenario where there is excessive production of the growth hormone in adults. And what is that condition? That is nothing but your acromegaly. So remember, in patients with the acromegaly, they can have hypertension. Alright, next. A point that you should remember is, not only in hyperthyroidism you have hypertension, even in hypothyroidism also you have hypertension. But in patients with hypothyroidism, you have what is called diastolic hypertension. In hyperthyroidism, it is systolic hypertension, whereas in hypothyroidism, it is diastolic hypertension. So, remember this point here. In patients with in patients with hypothyroidism, there is another endocrine disorder where the individual can have diastolic hypertension. Next, lastly, we have what is called as congenital adrenal hyperplasia. So, even in patients with the congenital adrenal hyperplasia, they can have this particular hypertension. Now, after having discussed about the renal pathologies and as well as the endocrine pathologies, now let me tell you what are the cardiovascular system pathologies where the individual can have the hypertension. Remember, you take the condition where you have the coarctation of aorta. In patients with the coarctation of aorta, most common site where the coarctation occurs is distal to the left subclavian artery. So, when there is coarctation distal to the left subclavian artery, what will happen is perfusion to the lower half of the body will be reduced. That is, the perfusion to the kidney is also reduced. So, once the perfusion to the kidney is reduced, there is activation of renin-angiotensin-aldosterone system, resulting in what is called as hypertension. So, the cardiovascular system pathology, it includes coarctation of aorta. So, and coarctation is very common in the distal to the left subclavian artery. Now, discussion on the drugs is very important because day in and day out, we will be prescribing the drugs to the patient. And not taking that into consideration, we will be thinking that the blood pressure of the individual is not under control. So, you should also check the list of drugs what the patient is taking. It might be because of the underlying drugs which will cause hypertension. Because of that reason also, the blood pressure of the individual may not be under control. So, you need to know what are all the drugs which will increase the blood pressure of the individual. So, if you take these particular drugs here, these drugs include mainly we have the oral contraceptive pills, right? Next, we have anabolic steroids. Right, anabolic steroids, corticosteroids if they are taken in excess quantities, right, corticosteroids. Next, we have NSAIDs, non-steroidal anti-inflammatory drugs. Then we have COX-2 inhibitors, right, COX-2 inhibitors. Then we have sympathomimetic drugs. Right, sympathomimetic drugs, and along with that we have certain anti-neoplastic drugs as well, that is your cyclosporin. And apart from these anti-neoplastic drugs, we have what is called as the other drugs include sibutramine, bromocriptine, right, bromocriptine, it is a drug which is given in patients with the prolactinoma. And next is erythropoietin, which we give in patients with the chronic renal failure. So, these are all the drugs which can cause hypertension. So, whenever you feel that or you are observing that in your patient the blood pressure is not being under control, you need to have a checklist of the drugs what the patient is taking. If any of these drugs, if the individual is taking, that might be the culprit for not having the blood pressure being under control. Next, apart from these particular drugs, remember even excessive alcohol consumption, right? Excessive alcohol consumption is another important factor where the individual can have uncontrolled blood pressure, or the blood pressure is not being controlled in spite of taking the appropriate medication. Now, apart from this particular alcohol and as drugs, you take in case of pregnancy. The pregnancy also, the individual can have the hypertension. So what is that clinical condition where the individual has hypertension in pregnancy? That is what is called as the preeclampsia. That is also one of the secondary cause for hypertension. Right? Now, apart from this particular pregnancy, you take the respiratory system pathology where the individual can have the development of hypertension. One of the very important respiratory pathology where the individual can have hypertension is obstructive sleep apnea, that is OSA. So these are all the secondary causes for the hypertension. So what do you mean by the word secondary hypertension? There is an underlying pathology, right? It might be the renal pathology, or it might be the endocrine pathology, a cardiovascular pathology, or the drugs and alcohol, excessive alcohol consumption, or during pregnancy, or in patients with the obstructive sleep apnea. So these are all the clinical conditions for secondary causes of hypertension. But remember, what is the most common cause for your hypertension? The most common cause for hypertension will be your essential or idiopathic hypertension. Next. Now, the other multiple choice questions that can be asked is, what are the clinical conditions where you have isolated systolic hypertension? That means only systolic blood pressure is grossly increased. Now, what is that? Let me tell you. So, common causes of isolated systolic hypertension. Now, if you take the common causes of isolated systolic hypertension, first and foremost, the very important cause is atherosclerosis. So you see in patients with atherosclerosis, the individual can have the isolated systolic hypertension. That means the diastolic blood pressure will be normal. Next, the another important valvular pathology where you can have isolated systolic hypertension is in patients with the aortic regurgitation. In aortic regurgitation, systolic blood pressure is very high and the diastolic blood pressure is very low. So where the pulse pressure is very high in patients with the aortic regurgitation. Next, apart from this, we have certain congenital pathology, which is an acyanotic congenital heart disease which can have associated development of hypertension. That is systolic hypertension. That is patent ductus arteriosus. So you see in patients with the patent ductus arteriosus, they will have systolic hypertension. Next, endocrine condition which can cause systolic hypertension is your thyrotoxicosis. That is in patients with the hyperthyroidism, they can have isolated systolic hypertension. Next to this, you have a cardiovascular condition where you can have isolated systolic hypertension, that is in patients with the coarctation of aorta. So in patients with the coarctation of aorta, they can have isolated systolic hypertension. Alright. So now, after having discussed about what are all the etiologies causing isolated systolic hypertension, let me tell you a very important clinical scenarios, that is, there are certain genetic disorders which are associated with the development of the hypertension. And this particular genetic disorder, we can classify them into autosomal dominant conditions and as well as the autosomal recessive conditions. So now let me tell you, even though these genetic conditions, they are very rare, but they can be associated with the development of hypertension. So this we call it as Mendelian forms of hypertension. So Mendelian forms of hypertension, as such, they are rare. And this Mendelian forms of hypertension, remember, we can classify them into autosomal dominant and autosomal recessive. You take this particular autosomal dominant conditions. Autosomal dominant conditions, they include what is called as glucocorticoid remediable hyperaldosteronism. So, autosomal dominant conditions are glucocorticoid remediable hyperaldosteronism. Okay, this is the autosomal dominant condition. Next, now apart from this, we have another autosomal dominant condition which is associated with the development of hypertension, that is called as Liddle syndrome. Right, that is called as Liddle syndrome. This Liddle syndrome I will be discussing in detail in the further part of the session. Next to the Liddle syndrome, we have what is called as Gordon syndrome. So even this particular Gordon syndrome, I'll be telling you what exactly this means. Gordon syndrome, remember, this is an autosomal dominant pathology which is associated with the development of hypertension. Next, the other autosomal dominant condition is in patients with the polycystic kidney disease. Remember, polycystic kidney disease, it can be of two variants. One is autosomal dominant and the other one is autosomal recessive. Autosomal dominant is the one which is seen in case of adults, whereas autosomal recessive is the one which is seen in case of children. Next, the another autosomal dominant condition is in patients with the pheochromocytoma. So, pheochromocytoma, it is a clinical condition which is characterized by the tumor originating from the adrenal medulla. Next, the other important autosomal dominant condition is hypertension exacerbated in pregnancy. Right? If you see this hypertension exacerbated in pregnancy, this is what is called as, or this is due to apparent mineralocorticoid excess syndrome. So, this is due to apparent mineralocorticoid excess syndrome. So, these are all the autosomal dominant conditions, right? Glucocorticoid remediable hyperaldosteronism, Liddle syndrome, Gordon syndrome, polycystic kidney disease, pheochromocytoma, and hypertension exacerbated during pregnancy. Next, let me take up the autosomal recessive conditions. If you take the autosomal recessive conditions which are associated with the Mendelian forms, which are very rare, let me tell you what are those autosomal recessive conditions. They are mainly because of certain enzymatic deficiencies. That includes number 1, 17-alpha hydroxylase deficiency. This 17-alpha hydroxylase deficiency, it is one of the autosomal recessive pathology which is associated with the development of hypertension. Next to the 17-alpha hydroxylase deficiency, we have what is called as 11-beta hydroxylase deficiency. So, 11-beta hydroxylase deficiency is an autosomal recessive form which is associated with the development of hypertension. Next, the other one is, the other enzyme what we have is 11-beta hydroxysteroid, right, 11-beta hydroxysteroid dehydrogenase deficiency. Right, dehydrogenase deficiency. So, these are the autosomal dominant and as well as autosomal recessive forms. So, these are basically the Mendelian forms, right, which are associated with the development of hypertension, and that too they are very rare. Now, going back to the question like what we have discussed, most common cause of hypertension in adults. So, what is the most common cause? Remember, the most common cause is your essential hypertension. Okay, essential hypertension is the most common cause. The remaining pheochromocytoma, renal artery stenosis, chronic glomerulonephritis, they're all your secondary causes of hypertension. Now let me tell you what is the cutoff of this particular blood pressure according to the newer guidelines. So we have the newer guidelines which have been given by the American Heart Association in 2017. Let me tell you what are the cutoff of the systolic and diastolic blood pressures according to the American Heart Association, which has been released in 2017. Now, so AHA stands for American Heart Association, right? AHA stands for American Heart Association. 2017 revised categories of blood pressure in adults. Right, revised categories of blood pressure in adults. So, now, according to this American Heart Association 2017 guidelines, let me tell you what is the normal blood pressure. Remember, normal blood pressure is if the systolic blood pressure is less than 120 millimeters of mercury and diastolic blood pressure it is less than 80 millimeters of mercury. This we call it as normal blood pressure. Next, when will you use the word that the individual is having elevated blood pressure? Right, when will you use the word the individual is having elevated blood pressure? The systolic blood pressure 120 to 129 and the diastolic blood pressure less than 80 millimeters of mercury. This we consider it as elevated blood pressure. Right, this we consider it as elevated blood pressure. Next, when will you use the word that the individual is having stage 1 hypertension? Right, when will you use the word that the individual is having stage 1 hypertension? Remember, stage 1 hypertension we use when the systolic blood pressure is in between 130 to 139 millimeters of mercury and diastolic blood pressure is 80 to 89 millimeters of mercury. That is stage 1. Next, you take stage 2. So, if you take stage 2, the systolic blood pressure should be more than 140 millimeters of mercury and diastolic blood pressure should be more than or equal to 90 millimeters of mercury. Now, when will you consider that the patient is having hypertension is, remember, individuals with systolic blood pressure and diastolic blood pressure in two categories, right, in two categories should be designated as having high blood pressure. That means minimum 2 times in the two settings the individual should be having a higher blood pressure, both systolic and diastolic. Then we can consider that the patient is having the hypertension. So these are the cutoff of the blood pressures according to the newer revised guidelines by the American Heart Association in the year of 2017. Now, let me tell you a little comparison of the previous guidelines. The previous guidelines were JNC 8, that is Joint National Commission 8 guidelines. So according to JNC 8, so if you take according to JNC 8, what was the cutoff of the blood pressures? So JNC 8, I will compare with the American Heart Association, which are the newer guidelines. You take in elderly individuals, right? You take in elderly individuals. What the JNC 8 tells is the cutoff for the blood pressure is less than 150 by 90. and elderly according to JNC 8, that is age more than or equal to 60 years. Right. You take according to the American Heart Association. According to the American Heart Association, in elderly, the cutoff for the systolic blood pressure is less than 130 by 80 millimeters of mercury. And according to the American Heart Association, elderly means the age more than or equal to 65 years. Okay. Next, you take in adult population. Right, you take in adult population. In adult population, according to JNC 8, the cutoff is less than 140 by 90. That is, in adults means age less than 60 years. Whereas, you take in according to the American Heart Association, in adults, it is less than 130 by 80 millimeters of mercury. Right? Next, you take in patients with the various underlying disorders. Right? Examples, if the individual is having either coronary artery disease, or the individual having diabetes mellitus, or the individual having the chronic kidney disease. In this clinical scenario, according to the JNC 8, the cutoff is less than 140 by 90. But according to the American Heart Association, it is less than 130 by 80 is the cutoff. So, these are little comparisons according or with the previous guidelines. Now after having discussed about the cutoff blood pressures in various clinical scenarios and according to the newer guidelines, so before starting the treatment, let me tell you what exactly will be the changes in the heart seen in patients with the hypertension. The question can be asked in this way. In essential hypertension, changes seen in the heart are the cardiac cell hyperplasia, cardiac cell hypertrophy, increase in the mitochondrial number, increase in the size of the mitochondria. Let me tell you, these are the questions which have been asked previously in the previous question papers or in the previous exams. Right? I will be giving you a completely different set of clinical based questions in the questions section. For each and every topic, I am giving you a clinical based questions and as well as the new questions, some of the new questions which have been framed by me. You can see them in the questions section. Right? These are the questions which I am showing you where the questions have been asked previously. Now, if you take in essential hypertension, what are the changes seen? Remember, whenever the individual is having hypertension, the afterload on the left ventricle is greatly increased because hypertension in the sense the blood pressure within the aorta is increased. So, once the blood pressure in the aorta is increased, the heart has to work very strongly to pump the blood from the left ventricle into the aorta. So, the afterload on the left ventricle is grossly increased. Now, as the afterload on the left ventricle is increased, what will happen to the thickness of the left ventricle is the thickness of the left ventricle also grossly increases, and thereby the individual will have what is called as the cardiac cell hypertrophy. So, in patients with the essential hypertension, the changes what you notice is the presence of the cardiac cell hypertrophy. Right? It is not your cardiac cell hyperplasia. Cardiac cell hypertrophy in the sense the size of the individual cell grossly increases, whereas hyperplasia, the number of cells increases. But here it is not the number of cells which will increase, it is the size of the individual cells which will increase. That is called as the cardiac cell hypertrophy. Now after having discussed about what exactly is the changes you will notice, let me show you how the questions can be asked on the treatment part. So, if you see the question here, management of uncomplicated essential hypertension is, the options are no need to treat, diet modification and as well as the exercise, diet modification, exercise and drugs alone. Now, in the part of the treatment, remember, we not only have the pharmacological drugs which we give for the treatment of hypertension. Along with this, we need to modify the risk factor for in the patient whatever they are. Until unless we don't modify the risk factor whatever is there in the patient, the drugs what we give may not be having that much efficacy in the treatment of hypertension. So now let me tell you first in the treatment part, what are the cardiovascular disease risk factors which can be associated with the development of hypertension. So in the treatment, so according to the American Heart Association 2017 guidelines, the screening and management of modifiable cardiovascular disease risk factors is also essential in the treatment of hypertension. So screening and management of modifiable cardiovascular disease risk factors, right? Let me tell you what are those. So in this, we have certain modifiable risk factors and then we have relatively fixed risk factors. Now let me tell you what are the CVD risk factors, that is cardiovascular disease risk factors. So as I have said you, this cardiovascular disease risk factors, we are having modifiable risk factors, and then what we have is relatively fixed risk factors. Now let me tell you what are the modifiable risk factors. If you see the modifiable risk factors, the cigarette smoking, this is a very important risk factor which is associated with the development of hypertension. It is a modifiable risk factor. You advise the patient to stop smoking. That can be one of the part of the management in the hypertension, right? So one is, this is a very important one, that is cigarette smoking. So next to the cigarette smoking, remember, it is not only the primary person having cigarette smoke, even the second hand smoking, right? This is also one of the modifiable risk factor. The other modifiable risk factors, they include diabetes mellitus, and the other important thing is the dyslipidemias, where the individual is associated with the increase in the cholesterol or triglycerides within the body. So right, dyslipidemia or increase in the cholesterol levels. Next, the other very important risk factor is your obesity or the overweight. These individuals, they are associated with the development of hypertension. And weight reduction can contribute nearly almost 10% reduction in the blood pressure, right? Obesity and as well as the overweight. Next, the other modifiable risk factors are physical inactivity. It can be associated with the development of hypertension, right? Physical inactivity or low fitness. And lastly, the very important one is the unhealthy diet. So these are all the modifiable risk factors which are associated with the cardiovascular disease, and if you can modify them, you can, to certain extent, you can manage the increased blood pressure within the individual. Next, now let me tell you what are the fixed risk factors. The fixed risk factors, they include chronic kidney disease, like the individual landed up in end stage renal failure. That is fixed. We cannot revert them once the individual lands up in stage 5 chronic kidney disease. Next, the other one is the family history. It is fixed. We cannot modify the family. So, family history. Next one is the increasing age of the individual, right? And male sex, they are more associated with the cardiovascular disease rather than the females. And the other one is your the obstructive sleep apnea. Lastly, psychosocial stress. Right? So these are all the fixed risk factors and modifiable risk factors. Now, in the part of the treatment of hypertension, we have two things. One, the lifestyle modification, and the other one is the pharmacotherapy. For the treatment of hypertension, just pharmacotherapy is not sufficient. Along with that, lifestyle modification is also very, very important. Now, after having discussed about what are exactly modifiable and fixed risk factors, next let me discuss the management of uncomplicated hypertension. Right? Management of uncomplicated hypertension. In this management of uncomplicated hypertension, we have lifestyle modifications, and next we have pharmacological therapy. Right? Next we have the pharmacological therapy. Now, first you take in the lifestyle modification is the weight reduction. Right? Weight reduction. How much should be the weight reduction is? The individual should able to attain a BMI of less than 25. Right? BMI of less than 25 kg per meter square. Next, the second one is the salt restriction. The dietary salt restriction of less than 6 grams sodium chloride per day is very important as a part of your lifestyle modification. So, salt restriction, that is less than 6 grams sodium chloride. Next, you need to adapt a particular type of diet which is called as the DASH diet. Right, which is called as the DASH diet. Now, what does this particular DASH diet includes? Remember, it is the diet, right? It is the diet rich in fruits, vegetables, and low fat products, right? And the diet should contain reduced content of saturated fat, right? Reduced content of saturated and as well as the total fat. So this is what is called as DASH diet, okay? And this particular DASH diet can reduce the blood pressure of the individual. Next to the DASH diet, alcohol consumption should be moderate if the individual is ethanolic. If it is in case of men, the individual can take up to 2 drinks. And if it is women, the individual can take up to 1 drink per day. So, in the part of the lifestyle modification, moderation of alcohol consumption. And what did I have said you? 2 drinks per day in case of men, 1 drink per day in case of women. This is being permitted for the individual to have an adequate blood pressure. Next, apart from all this, the physical activity is very, very important. Right? Apart from all this, the physical activity is very important. So, the individual should do a regular aerobic activity. Right? The individual should do a regular aerobic activity. That is for nearly around 30 minutes of brisk walking. Right? So, these all will be the lifestyle factors which have to be modified where the individual blood pressure should become normal. Next, you take the pharmacological treatment. Remember, as a part of the pharmacological treatment, you can start either the AC inhibitors or the angiotensin receptor blockers. These are almost like first line medication in those individuals of age group less than 50 years. Whereas you take in case of elderly individuals, you can start those patients with the calcium channel blockers, right? Next, the important group of drugs what we have is the diuretics as well, and that too, which group of diuretics are used in the treatment of hypertension is thiazide diuretics. Right, it is your thiazide diuretics. Remember, thiazide diuretics are given when the individual is having hypertension, but if the individual is in a state of hypertensive crisis, then the loop diuretics are useful in order to manage that very particular or that very high blood pressure. And if the individual is having the blood pressure not being controlled with the monotherapy, then you have to give what is called as the combined therapy. Right, you have to give what is called as the combined therapy. So, this will be the treatment of what? Uncomplicated hypertension. So, in uncomplicated hypertension, along with lifestyle modification, you also require the pharmacological drugs that need to be given for the patient. So, if you go back to the question here, management of uncomplicated essential hypertension is, so the answer is the diet modification, exercise and as well as the drugs. Now, let me tell you what are the antihypertensives you have to give in an individual with underlying clinical scenario. Now, let me discuss that. Now, for example, if the individual is having hypertension, along with hypertension, if the individual is having proteinuria, right, along with hypertension, if the individual is having proteinuria, in this clinical scenario, the group of drugs what you have to give is AC inhibitors or angiotensin receptor blockers. These AC inhibitors and angiotensin receptor blockers, they will reduce the proteinuria within the individual by reducing the intraglomerular pressures, because these AC inhibitors and ARBs, what they do is efferent arteriolar dilatation. Once there is efferent arteriolar dilatation, the fluid from the glomerulus will enter into the efferent arteriole. So, the intraglomerular pressure reduces and that will reduce the proteinuria. So, that is the reason why you have to give ACE inhibitors or ARBs. Particularly, you have to give ACE inhibitors. But if the individual is intolerant to ACE inhibitors, then you have to give angiotensin receptor blockers. Next, you take in a patient with the hypertension, and along with that, the individual is having diabetes mellitus. Remember, even in this clinical scenario as well, you have to give the same drugs, that is ACE inhibitors or ARBs. Now, the question is why? Because these patients with the diabetes mellitus, there is a very great chance that they can develop what is called diabetic nephropathy. So, once the individual develops diabetic nephropathy, they can have proteinuria. So, in order to reduce the proteinuria, again we give ACE inhibitors or angiotensin receptor blockers. Next, you take in patients with the hypertension plus diabetic nephropathy. So, as just now we were discussing, it is mainly the ACE inhibitors or ARBs that has to be given. Alright. Next, now after having discussed about the individual drugs that need to be given in patients with the uncomplicated hypertension, let me show you a clinical scenario where the individual is having hypertensive crisis. Now you see the question here. A person has headache and the individual is having profuse sweating as well. And on examination, his blood pressure is nearly around 200 by 120 millimeters of mercury. Which of the following drugs should not be used? The options are nifedipine, sodium nitroprusside, the phenoxybenzamine, methyl dopa and as well as labetalol. So which among these should not be given in patients with the blood pressure of nearly around 200 by 120 millimeters of mercury?